Right, hi, welcome to Spinal Cord. We begin with the intermediate spinal cord regions. We're not going to go through, in the 2020 edition of the syllabus, the ascending and descending tracks that have been covered in Block 3 in preclinical anatomy, because you should already have comprehensive notes on those, and there aren't many to know. Okay, you need to know your dorsal column medial lemniscus system, you need to know your ascending cerebellar tracts, you need to know your corticospinal tracts that descend down, basically, and then maybe reticulospinal, rubrospinal, lateral vestibulospinal. But those are all in 2 lectures that the anatomy and imaging team at Warwick have given you already. So we're going to jump straight into this that breaks the rules. Descending tracts in the posterior white column. Now what's going on there? Well, it turns out that you've got 2 tracts here, gracilis and cuneatus. Gracilis is lower limb, cuneatus is upper limb. Cuneatus or burdox fasciculus is this wedge-shaped fasciculus here because it sort of sticks between the dorsal horn of Gray and the fasciculus gracilis here. But there are 2 other tracts that are hard to see unless you do a dissection, have specific stains. The septomarginal, because it's at the margins of this posterior septum here, and then this comma fasciculus named after its shape. So this one's named after its location, this one's named after its shape. It has a few other names, but comma fasciculus will do. Now, these 2 different tracts here are only visible in severe dorsal column atrophy, so tabes dorsalis, tertiary neurosyphilis, right? And these are propriospinal tracts. These are fibers about proprioceptive information that are descending into the spinal cord to help with the cross-regulation of the dorsal column. You will, if you start to see this on imaging, like MR scan of the spinal cord, the patient has really severe dorsal column atrophy, which only points to a few certain things. So, 90% of the marks will come from gracilis and cuneatus, but there are a few here that are up for grabs with these extra things. So tabes dorsalis. So, brief nudge here talking about the pyramidal versus extrapyramidal system. The pyramidal system is comprised of, as we know, the upper motor neurons running in the corticofugal pathways. If you're not familiar with corticofugal, see some of our earlier lectures, but they run together. In the midbrain, they form the cerebral peduncles. In the pons, they form the front of the pons, the big fat pons, and then they're the pyramids running around the olives here of the medulla, where they then decussate. So this red structure here, this is all the pyramidal tract-based system. Okay? So see block 3 for a bit more information on this, but these are the key constituents. You have your upper motor neurons coming from M12, S12. Layer 5 is where they usually originate from. Remember we said there's a 6th layer to the neocortex. They descend through this corticofugal pathway. Okay? And that's what they look like, as we said. Now the extrapyramidal system, by definition, is not going to be this upper motor neuron pathway. It's extra to it. It's another set of stuff. So let's talk about its constituents, what makes up the extrapyramidal pathway, and then let's talk about the modulators. So we have our reticulospinal tract, we have our rubrospinal tract, our tectospinal, and our vestibulospinal tract. So we'll go into more detail about what those are, because those are new, but these 2 we've seen before. So rubrospinal controls the flexors, okay? The gravity muscles. When you bend over to do some gardening or to sweep the floor up with your little dustpan and brush, kind of thing, you're flexing your body down with gravity, and that's the rubrospinal tract. The vestibulospinal tract, getting information from the 4 vestibular nuclei and then descending down to modulate balance unconsciously, is going to be the remit of the anti-gravity muscles, extension, so standing upright, you're extending your trunk upright. So these 2 modulate together, they agonize and antagonize each other to keep you balanced. But these 4 are all modulated by the nigrostriatal pathway, coming from the substantia nigra and projecting up to the putamen and other areas, the basal ganglia themselves, the cerebellum, and the vestibular apparatus. So these all modulate these, and this entire apparatus structure here is the extrapyramidal system. So it's the other stuff in our body that aren't those upper motor neurons that are helping you with balance, basically. The TLDR of this is that the pyramidal system forms the upper motor neurons to synapse with lower motor neurons, but the extrapyramidal system forms the regulation of those lower motor neurons, or ventral horn cells as they're also called. So you need to know the difference between an upper and lower motor neuron, which is very bread and butter, these deficits, and there are mnemonics like hens are my farmhouse or Sam, which is what I prefer. So make sure you go away and have a look at that. There's a descending tract lecture that covers phase 1 descending tract anatomy where I go into this in more detail, which will be linked below if you don't remember this, but it's very quick to just sort of think through the differences that would result. So yeah, the TLDR. But if we look at the extrapyramidal system, think about Parkinson's disease. It's a trap, right? So trap me is the mnemonic for Parkinson's. So tremor, rigidity, akinesia-ish, because it's actually bradykinesia, and postural instability. Micrographia and expressionless, so the mask faces. Okay, so these are the classic signs trap me for Parkinson's disorder, and that's because the upper motor neurons are projecting fine, but their regulation to the extrapyramidal system because of loss of basal ganglia, nigrostriatal projection fibers, means that dopaminergic input is not working. So the direct and indirect pathway are not working properly, so you end up with the trap me signs. So spinal cord lesions, we're going to go through a few of the really important ones that you need to know for basic neurology here. So the lesions are in red. So if you have lesions here at the soma of the lower motor neurons coming out, this is classic of polio. It's also classic of SMA, spinal muscular atrophy. And these patients are going to have incredible flaccidity and atrophy and weakness because of lower motor neuron signs. So the lower motor neuron cell body is destroyed. So those are the signs they'll have. Now this is a very disparate, almost patternless, there's no rhyme or reason to this. So this is classic of multiple sclerosis, okay? It's random loss of white matter, but it preferentially occurs in the cervical region. So you have weird lesions on transverse MR, but it's preferentially cervical. This is the hemisection, which is Brown-Séquard syndrome. And so you will have contralateral loss of pain and temperature 1 or 2 levels below, because remember that your spinothalamic tracts come in, they rise up 1 or 2 levels in Lassaro's tract, and then they decussate over via this anterior white commissure here. So they come in, they go up, this shouldn't be like that, so they go in, they come up through Lassaro's tract 1 or 2 levels, and then they decussate over and then run in the spinothalamic tract and go up. So you will have step down, because it's 1 or 2 levels, and it's contralateral. But the decussation of the dorsal column isn't until you get to the internal arcuate fasciculus within the medulla, so you'll be ipsilateral for dorsal column sensation, right? So 1 or 2 levels down, and it's contralateral for pain, but it's ipsilateral, same level for dorsal column. So those are the 2 key ones you need to remember, because the other stuff is unconscious or minor regulatory. So there's a few other signs that you would pick up for neurological and neurosurgical examinations, post-grad exams, but for med school, these are the ones you need to know. Now, what is this? So this at first glance appears like SMA or polio, but we have injury here as well. So this is ALS because this is a combo of upper and lower motor neurons. So this is the corticospinal tract, the lateral corticospinal tract. So your upper motor neurons are lesioned and your lower motor neurons are lesioned. So amyotrophic lateral sclerosis is a combo of these things, and it usually occurs distally. So it starts in the manus, which is the anatomical term for the hand, and it progresses proximally. So you'll have guttering of the hand muscles, like the first dorsal interossei is quite a common one to be affected, and then up it spreads basically. But the dorsal column is preserved and oculomotor function is preserved, so you can still move your eyes basically. So there's a lot of communicative assistive devices that enable that to help you basically. So what is going on here? Well, we've added in these little structures here. This is the anterior spinal artery, and these are the posterior spinal arteries. So we have the posterolateral fissure here, or sulcus, into which the 2 posterior spinal sit, and then anterior spinal here, where the anterior median fissure sits. This is an anterior spinal stroke. It spares the dorsal horn, but you have everything else affected. So it's sort of like your ALS lesion, but on steroids here, right? So everything is affected, but there's sparing of the dorsal horn. This one here is central canal syndrome. Now, in central canal expansion, you will have upper limb over lower limb paralysis, and that's just because, so remember, paralysis is weakness, so it's motor, and that's because the topographical arrangement has the lower limb out here, so it tends to be affected later. But the cervical, thoracic, lumbar, sacral sort of arranges like that. So in central canal syndrome, you have cervical, then thoracic signs, then lumbar signs, then sacral signs for your low motor neuron lesion. Now this is posterior horn. This is what we talked about before. This is tabes dorsalis, tertiary syphilis. So remember that your comma and septomarginal fasciculi will become apparent because they're left alone by tertiary syphilis. So this neurosyphilis just goes for your gracilis and cuneatus fasciculars. So you have dorsal loss of epicritic or fine touch, proprioception, vibrational sense, and you have the sensory ataxia. So because the dorsal column is not bringing up that conscious proprioception, you do an over-exaggerated, like wide stepping gait. So it's like when you've got a pair of wellies and you're walking through a muddy field and you sort of lift your leg up and it goes squelch, squelch, but you've lifted your leg up really high. This is really high clearance. That's what the wide stepping gait of posterior column loss is like. And then here we have syringomyelia. So this is a syrinx of CSF, so we get an expansion there. And this causes cape-like bilateral loss of pain and temperature. And that's because, remember we said spinothalamic comes in and it decussates here at the anterior white commissure. So the syrinx will compress here preferentially and knock out bilateral, because one's coming in this side, one's coming in that side. So it knocks out bilateral pain and temperature in a cape-like distribution because, again, it's preferentially cervical. Now, we've got a few structures here, haven't we? This is posterior column and spinocerebellar tract. So corticospinal's here, but spinocerebellar is more lateral. So this is B12 deficiency, very classically. So we have lateral corticospinal, just briefly touched, spinocerebellar tract touched, and the dorsal horns. Those are the things that result in B12 deficiency, and it's bilateral and it's diffuse, so that should give you an idea. You lose epicritic touch, you lose vibration sense, proprioception sense. You have upper motor neuron signs, and the proprioception is particularly worse because your unconscious proprioception can't compensate either. So you lose conscious and unconscious. So imagine a B12 deficient patient's Romberg sign in this. And then when you have upper motor neuron defects, they'll have spastic paralysis, there'll be hyper, up reflexes, Babinski, clonus, all of those different upper motor neuron lesions. So, the few extra tracts that we mentioned before, spinotectal, so remember that tectum is the midbrain, and the tectum is the corpora quadrigeminus, so your superior and inferior colliculus. So it descends up to the superior colliculus. And this is to enable you, if I stroke your cheek, you turn towards that movement, or you slap me in the face, but you turn towards that movement, and that is spinotectal derived. So that is cutaneous information moving, your going from, well, not the cheek if it's spino, okay, let's say it's your arm, right? So I touch your arm and your eyes move towards that stimulus. That's spinotectal, because superior colliculus, remember, is eye movements and vision, inferior colliculus is audio. Your spino-reticular system is collaterals from the anterolateral spinothalamic tracts to the reticular formation. So if you're getting some nasty noxious stimulus, it'll come up the spino-reticular tracts, jump into the reticular formation, and cause further arousal and agitation through those reticular activating systems. Spino-olivary arise from the spinal cord at all levels and go to the inferior olivary nucleus, and it's the commencement of that olivocerebellar tract. And as a revision, what kind of fibers originate from the olivary nuclei and project towards the cerebellar cortex? That's something for you to try and remember. So this talks about the different kinds of spinothalamic tracts. So you get a bit of pinprick here, conveys the dorsal horn, dorsal root ganglia there, so into the dorsal horn. But before it gets to the dorsal horn, it ascends up a few levels into Lazara's tract and then crosses over the anterior white commissure, runs in the spinothalamic tract up through the medulla to the nucleus of the VPL of the thalamus and then up to the somatosensory cortex. Now, we've talked about the spinothalamic tract, the anterolateral system. So the lateral system is your neospinothalamic tract, and that deals with more complex pain modalities and more things like that. But your anterior spinothalamic tract bifurcates into archae and paleospinothalamic, and this is really in the weeds of neuroanatomy here. These terminate in the reticular formation, so these are part of the arousal of noxious stimuli beyond the spino-reticular system. Okay, so your neospinothalamic is making you consciously aware of the noxious stimuli, but your anterior spinothalamic, which runs relatively close to it, has a different function altogether. If you're interested, these are the different types of nerve fibers which are important to know about. I know that it was mentioned in block 3, but not particularly too well. There's 3 A fibers and a C fiber. So your A alpha, beta, and delta. Your A alpha is proprioceptive, and it's myelinated, so it's pretty quick. Or your C fiber is pain, but it's non-myelinated, so it's slow. So this is more of your dull, throbbing pain. A delta and C fibers are married together because this is a quicker one. It's myelinated, right? So this is your sharp pain, so you can feel the pain. Touch is quite quick. It's quicker than your A delta fibers, and that's so you can pick things up with stereognosis. You can think about, what's in your hand. You can search for things. You can also modulate the depth of which pressures and things should be related to you. Your A alpha fibers, proprioception, are moving super quick, and that is predominantly because, I don't know why they chose a jumbo jet, should have a Concorde or like I don't know, the Millennium Falcon or something. There was a second Star Wars reference. This is because you need to constantly be modulating your balance. It requires a lot of effort. That's why there's a conscious proprioceptive system and an unconscious one. So it's working massively over time to give you this feedback, basically. This becomes important because we use all 4 fiber types for the gate control theory of pain. So you get a pinprick. The A delta myelinated fibers convey that stimulus into the central nervous system, and then you feel pain. Okay? And then later on, after A delta has been stimulated, the C fibers, if there's an irritation there, so inflammation, all these other different kind of things, there's a whole array of neuropeptides that are released, like substance P and the like, and all of the prostaglandins and interleukins. They trigger the C fibers to continue firing. So you've got the initial pain, then you've got dull ache for a couple of days afterwards. Okay? But as well as doing this, these A delta and Charlie fibers send information to the central nervous system and to a peripheral inhibitor neuron, right? But they turn off the inhibitor neuron because I want the central nervous system to know I'm in pain. But if you then rub it better, Wall and Melzack in the 60s described this phenomena, that you have A alpha and A beta fibers, remember your proprioception and touch fibers, that when you rub the area where you've been pinpricked, these say, actually, I want you to focus on the rubbing instead. And they go to the central nervous system to say, hey, there's some rubbing going on, but they also go to this peripheral inhibitor neuron, which says, no, this rubbing is more important than this pain. So I want you to turn on this inhibitor neuron. And this inhibitor neuron comes and makes sure that the A delta and Charlie fibers aren't transmitting to the central nervous system. And that is the rationale of Melzack and Wall's gate control theory of pain, okay? The gate theory. So you need to know your A alpha, beta, delta, and Charlie fibers, their relationship for the gate control theory. And that's Moxham core for that kind of thing. Specifically says gating theory. So what we'll do now is spasticity, rigidity, tremor, spasms, athetosis, chorea, dystonia, myoclonus. Well, we've covered most of those in a previous lecture when we were doing movement areas. So instead what we're going to focus on is the difference between spasticity and rigidity. This is core upper and lower motor neuron findings for your upper and lower motor neuro exams, right? So spasticity of the etiology is upper motor. You have all the upper motor neuron signs with strength, stretch, reflex, atrophy, myoclonus, Babinski, and muscle tone. But you also get clasp knife. Okay, so you're opening. You know that you initially you try to flex, and there's resistance, then it gives way, bang, and then snaps shut. So it's that clasp knife movement. It is velocity dependent. So this thing is more noticeable as speed increases. So the more pressure you apply, the quicker you try and do a movement, the more the upper motor neuron spasticity will appear. This is in contrast to rigidity, which is lower motor, which is an extrapyramidal issue. So these are cogwheeling, Parkinsonism, and lead pipe. So lead pipe is actually really important when you see that. This is velocity and direction independent. So it doesn't matter which direction you put it in, it doesn't matter how quick you go, it's the exact same rigidity. The extrapyramidal system does not care about velocity. Remember, the upper motor neuron is regulatory to the lower motor neurons, but the extrapyramidal system is more about finessing, a higher up thing. So that's more the finessing of the upper motor neuron. So if you have a loss of that finessing issue, that's what happens. We've already done that learning outcome, so that's fine. So the arterial supply of the spinal cord roots and rootlets. So the anterior spinal artery goes to the anterolateral spinal cord. The posterior spinal grabs the rest of it, but there's also the radicular artery, which goes to the roots and rootlets, and also supplies these giant spinal arteries. So here's our spinal cord, here's anterior, here's posterior. We have our two posterior spinal arteries, we have radicular branches coming in here, and then we have the anterior spinal artery and the anterior median fissure. It arrives traditionally off the vertebral artery and courses in this anterior median fissure. Okay, so just remind yourself of this. So here we have our our vertebral arteries that unite to form the basilar. And this little structure here is our anterior spinal artery. So the two come together and form the anterior spinal artery. Here's our posterior spinal artery. This is the posterior view of the spinal cord. So we have our two posterior spinal arteries there. And here's what it looks like in cross section. So we have our anterior spinal artery giving branches here. This is actually called the central artery, the anterior central artery that runs in this anterior median fissure off of the anterior spinal. And then we have two posterior spinals in this posterolateral sulcus. So there's an anterior median fissure, a posterior fissure, a posterolateral sulci bilaterally. Now our posterior spinal arteries here, these are coming off the vertebral arteries as well commonly, so that's quite nice. They have a common origin, the anterior and posterior spinals. They run in the posterolateral sulcus, which is normally quite small, you can't really see it very well. They supply the rest of the spinal cord, yeah? So this anterior supplies the anterior anterolateral 2/3, and then the dorsal columns are supplied by the posterior spinal artery. The radicular arteries, radicular like a circular thing, crowning area, comes off of the vertebral, intercostal, and lumbosacral artery. So it comes off a lot of different levels. And they supply the roots and the rootlets. So here is a radicular artery, and you can see it running around to form this lateral plexus that supplies all these different branches and helps support the roots, rootlets, as well as the spinal arteries, the anterior spinal artery, the posterior spinal arteries. So here's your anterior spinal artery, here's your posterior spinal arteries. So your anterior and posterior spinal arteries form this arcade around here with perforations coming in. The radicular artery here is supplying the anterior medial artery and helping to supply the lateral plexus. And that's how it will indirectly supply the posterior spinal artery as well. So you can see here's a spinal ramus coming in, and then off of this will be a branch that supplies meningeal structures and periosteum, but then into the dorsal root ganglia here and into the rootlets comes an anterior and posterior radicular branch that supplies the roots before anastomosing with posterior spinal and with anterior spinal. And that's what happens. So these spinal rami coming off the vertebral, the intercostal, the lumbosacral, the whole array of stuff comes in and supplies the roots and rootlets. Veins of the spinal cord are similarly named, but note that they will be draining into the azygous system. That's system. Okay, don't worry too much about these because the veins, as in all veins in the body, are highly variable. Just make sure that you know the concepts, that they're draining into the azygous venous system and they run with the arteries. Okay, so here's actually a really good example of the aorta giving off an intercostal or a lumbar artery, giving off a spinal branch here, which will cause a branch to come around here to supply the dura, so it runs in the epidural space. But then also a deep diving radicular branch that runs anteriorly and posteriorly, and the anterior one supplies the anterior root, and then goes to the anterior spinal, and the posterior one supplies the posterolateral sulcus's posterior spinal artery. The only thing to be aware of with the venous system is that they drain into the epidural venous plexus. And the epidural venous plexus is very communicative, and it runs right the way up through the foramen magnum to communicate with the dural venous sinuses. So METs, when they get into the epidural space there, will basically head up to the brain from the vertebral column, and that's why you get a lot of brain METs in those different conditions. So, acute spinal cord injury and compression, not to go into too much detail because it's quite straightforward. You have a spinal trauma or a compression from METs or prolapse. That's your classic etiology of a spinal cord injury. It's going to cause paresis, paresthesia, sphincter and erectile dysfunction, quite obviously, at the level or below the level of the lesion, right? Investigations, imaging to see the extent of the damage and then to see the extent of the swelling, and the management is to control the swelling or to remove any compressions or prolapses if required. So glucocorticosteroids, surgical and radiotherapy as warranted. So just a little bit of information on spinal cord injury there. So we've already covered these tracts, these intersegmental tracts, with what we've said with the comma and the septum marginal. These are just other names for these tracts, basically. They're the propriospinal fibers. We've covered most of this already, so we will just briefly revisit hemibolismus, which is your contralateral subthalamic nucleus, causing a hemibolismus. Tabes dorsalis, the tertiary neurosyphilis from the dorsal horn predominantly, giving us the two propriospinal tracts appearing. This causes ataxia, the sensory ataxia, the stepping gait, the loss of proprioceptive sense, a positive Romberg's finding. Pernicious anemia, so your B12 deficiency, the dorsolateral horn demyelination, and then your weakness and unsteady gait as a result of that. And then we'll briefly mention a rhizotomy versus a chordotomy. So selective dorsal rhizotomy knocks out the dorsal rootlet here. So constant chronic pain that's firing and is resistant to neuropathic pain treatments like your TCAs, your gabapentin, like. If it doesn't work, you can do a rhizotomy, which will cut this horn here. It's SDR, it's called selective dorsal rhizotomy. Cuts this horn so the impulse doesn't transmit, but then you're cutting the dorsal horn, so all of that afferent information at that level isn't coming in. A more dramatic form is a chordotomy, which is where you basically go in and you ablate that particular region of spinothalamic tract. So it's just a more central, basically, type of the same thing. And that's for intractable pain, right? Intractable neuropathic pain.